Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Lilly.
Hi, and welcome to this Medscape Education program on Alzheimer's disease diagnosis, response, and the neuroradiologist and nuclear medicine specialist, tactics, strategies, and best practices. My name is Tammy Benzinger. I am a neuroradiologist at Washington University in St. Louis. And coming to you from my roles as a medical director of our MRI section here, as well as my involvement in clinical trials. I'm sharing with you up front these links, and these will be available at the end as well. There are updated society and consensus guidelines that are available to talk about dementia imaging. These have been coming from the Alzheimer's Association, the Society for Nuclear Medicine and Imaging, the American Society for Neuroradiology, and also the American College of Radiology. And they all have some really nice detailed scenario type information that can help guide practice decisions. Now, big picture, why do we care about this, and why is this changing? Well, for a long time, what we focused on in terms of Alzheimer imaging was that end stage of the disease. So we would look for patterns of atrophy. And you can see here as an example of what a brain with Alzheimer's looks like at the end stage. This is an autopsy. Very widespread atrophy, but in particular, atrophy of the hippocampus and the temporal lobe, and exvacuodilatation of the lateral ventricles. And of course, we've known about this since the dawn of MRI. So I love to go back and look at some of these older publications. So this was from 1992, one of the first studies looking at the brain changes that you can see on an MRI and how closely those parallel what was seen at autopsy. So we've known about the imaging of dementia with MRI for the past 30 years. Now, what's changed more recently has been the advent of molecular imaging for Alzheimer's disease. And in particular, there are now FDA-cleared tools for visualizing the two hallmark pathologies of Alzheimer's disease, the amyloid plaques, as well as the tau tangles. And because of changes in therapy that's been happening, I'm sure many of you, if you're practicing in the US, you've been seeing a really large increase in requests for MRI and for amyloid PET. And depending upon your region, some places are also seeing large numbers of increases for tau PET as well. And so what I'm going to walk through is how these tools can be used, what types of patient situations they're helpful for, and also what do we need to think about when we are both when we're getting a request for an imaging study, but also when we're interpreting that study afterwards. So, so just to begin with, what we now know is that atrophy is the end stage of a very long process that begins about 20 years before symptoms with that amyloid deposition. And the amyloid deposition can be measured by spinal fluid, where you'll see drops of the amyloid species, or positivity on an amyloid PET scan as it starts to accumulate. And this is in that pre-symptomatic phase. The tau deposits come much later, and these appear right around the time that people are first having either mild cognitive impairment, we call MCI, or early Alzheimer dementia. And actually, in most cases, the neurodegeneration the atrophy that we see on the volumetric MRI or the drop in metabolism on an FDG PET scan is at that end stage of the disease. And so which test you're getting to begin with also depends upon which stage of the disease the patient is that you're thinking about. Okay, so very, very common question that comes to our reading rooms all the time is, what test should I order first? And so here I'm sharing with you the ACR, American College of Radiology, updated appropriateness criteria in 2024. And you can see that brain MRI, amyloid PET, head CT, and FDG PET may all be appropriate depending on the scenario. If you happen to be in an urgent situation, so a patient comes into the emergency department with new confusion or impairment, then that's obviously, you're going to want a fast test like a head CT to identify those urgent treatable causes. And this is just an example of a patient with a subdural hematoma that you can quickly identify on that head CT. In the past, we would do our next step of the exam would be the non-contrast brain MRI. And that would be to exclude other causes. And this is an example of a patient with normal pressure hydrocephalus. So the ventricles are too big. So that's another cause of dementia. What we now have to have in the back of our minds is that this MRI visit should also be able to address eligibility for therapies if they are determined to have Alzheimer's disease. And then, of course, then the next step would be a PET scan. And really, which type of PET scan you would get is going to depend upon those specific symptoms and scenario that the patient is coming with. So if it's somebody that has very early impairment and the neurologist thinks that it is probably an Alzheimer type pathology and that they might be eligible for therapy, the imaging test we would want to do would be specific to Alzheimer's disease, would be an amyloid PET. If, on the other hand, their symptoms are more confusing, maybe they wax and wane, maybe they have a language focus, maybe you're thinking maybe frontotemporal dementia, or in this case, this is an example of a patient who had a chronic limbic encephalitis. So you can see the hyperintense flare signal in the mesial temporal lobes matched by hypometabolism on the FDG PET scan. So which PET scan you do next really depends upon that integration process of the symptoms. For the MRI, and this is new and has changed, because the therapies have a problem of something called amyloid-related imaging abnormality, or ARIA, the patients on therapy can get vasogenic edema, and they can get microhemorrhages, and they can also get small subarachnoid hemorrhages that manifest as siderosis on the MRI. So because of those particular findings that we're going to be looking for during therapy, we need to make sure that our dementia MRI protocols have the right sequences in order to identify those findings. I think everybody is already performing FLAIR, so that's not a big deal. The issue is that the microhemorrhages, if you don't run your sequences correctly in order to detect them, they may be hidden. And so this is where running the right protocol is really important, both for baseline and for monitoring. And this is a link on this slide that can take you to the ASNR website that can get you links to downloadable protocols, as well as more details if you want to try to build it yourself on the scanner. The other thing that is new and important is structured reporting. So I highly recommend you build out templates, and these are also available through the ASNR for these MRI scanners, calling out specific things like the field strength, the technique that was used to identify the microhemorrhages or siderosis, grading the white matter hyperintensities with a standardized scale, quantifying these small, large infarcts, microbleeds, et cetera. So all of these are criteria that are needed for therapy and are needed for monitoring. And here's the thing, if you don't put these in your report up front, you will be asked to make addendums. And we are all so busy in radiology right now. I think none of us have time to read a scan twice. So I highly recommend you make sure you're running the right protocol and reporting it with the right reporting structure so that you don't get a lot of phone calls and rework. Okay, now, what about amyloid and tau PET? So this comes out of the work of the Alzheimer's Association and Society for Nuclear Medicine. So if somebody has a high degree of suspicion for Alzheimer's disease, whether it is mild cognitive impairment or dementia, an amyloid PET is almost always appropriate. So this grading scale goes from 1 to 9, with 7, 8, and 9 being in that somewhat to highly confident that this would be helpful. You can see that the tau PET may also be helpful in certain situations. In this case, it was determined that the tau PET may additionally be helpful if someone is younger than age 65, or if they have atypical features. So when is it not appropriate to get an amyloid and a tau PET? I think this is also really helpful to walk through. So somebody that is not cognitively impaired, so someone with normal cognition, they are not eligible for these therapies, and so these scans are not appropriate to use. What about non-medical use? So medical legal, establishing competency or something. That is not an appropriate use for the amyloid and the tau PET. And then finally, what about should we use these PET scans instead of genetic testing to identify risk? And again, this was also not recommended. Okay, the next question, this comes up a lot. What if they already had biomarker testing? And in this manuscript, we focused on the spinal fluid. Of course, I think many of you listening will know that in May of 2025, the FDA also cleared a blood test, which is also now being used. And I think you can sort of think of this the same way, which is if the CSF was performed and it had a clear result, then it's probably not appropriate to get that amyloid PET scan. But if there's something about that CSF that was inconclusive or equivocal, then an amyloid PET scan can be very, very helpful and may determine the next course of therapy that the patient gets. All right. And so speaking of therapy, so this is the big thing that has changed in the last 2 years. So in order to determine eligibility for therapy, an amyloid or tau PET is considered appropriate. Also, if you're monitoring patients on an amyloid therapy, a follow-up amyloid PET scan may also be appropriate. So I can tell you, at our institution, we're now getting amyloid PET scans after 18 months of therapy on almost all of our patients. And that's being used to determine what changes to therapy might be instituted after that 18 months. When they get that, though, they're really asking us for quantification because they're trying to assess the response. So just to back off a little bit and talk about these treatment strategies. So I mentioned there are those 2 hallmark pathologies in Alzheimer's disease, the amyloid plaque and the tau tangle. The therapies that are currently approved in the US are both focused on the amyloid plaque. What we have now in the US is lecanemab, and this came out of the Clarity AD and AHEAD studies. We also have donanemab, which came out of the Trailblazer studies. And why does imaging come into this? Well, a key finding for all of these studies was target engagement was confirmed with amyloid PET. So this is an example from the aducanumab trial, a patient on placebo whose amyloid PET scan is positive and remains positive versus someone treated, and you can see the clearance of the amyloid. All right, so tau PET was also used in the Trailblazer study to stratify the patients at the study entry. And they were looking for patients who had early impairment, but also really found that that people with that low intermediate tau pathology were the ones who responded best to the treatments, which makes sense. So you're looking for people who have a very early stage of their Alzheimer's disease. And as I mentioned, we do have FDA clearance for tau PET in the US, and there are FDA cleared software tools which can be applied to help you get that estimate of that stage of the tau. Now, how about, let's come back to this again, this question about amyloid and tau PET in the setting of amyloid therapy. Eligibility at the beginning, as well as the follow-up to the therapy. And in both cases, for the amyloid PET, having the quantification is very, very helpful, especially if you're trying to assess that response. It's nice to know the quantification before and after. Tau PET may also be helpful in that stage of eligibility. And again, this comes out of those lecanemab and donanemab trials. Amyloid PET quantification. So there is a standardized scale. It's called the Centiloids. And this harmonizes across the various FDA cleared amyloid PET tracers. And so unlike an SUVR, which is going to be more tracer specific or processing software specific, and it can help you when you're trying to analyze those scans in order to, it really aids that visual interpretation for a lot of people to have that result. And it gives the referring physician something concrete to understand more than just a positive or negative. And this is just to show you an example from our study. So we had a patient who had a research amyloid PET scan way back in 2017. This was using carbon 11, Pittsburgh compound B. Visually, you can see it's a positive scan, and it has a centiloid value of 73.4, so a positive scan. They then came on therapy here at Washington University, and this is the follow-up scan that we acquired clinically. And this is where it's so important. So visually, you can see it's still a positive scan, but you see the amyloid PET centiloids have dramatically reduced to 26.5. Now, each center is using this different ways. At our center right now, if the amyloid PET after 18 months of therapy is below 30, they're oftentimes offering this patient a change in their infusions. Okay, so this really was meant to help all of you anticipate the questions that are going to be coming in. So we are now getting very, very high volumes across all of these modalities. And very commonly, there's a question about which PET study should I start with? And so again, the idea here is the amyloid is very, very early pathology. And so if somebody's being considered for therapy, that is probably the right one to get. Versus if somebody has more advanced disease or a complex presentation, that's where your FDG PET may be where you want to start. When is repeat imaging appropriate? So right now, a lot of places are getting a repeat amyloid PET after 18 months of therapy. It might be helpful to go back to bookmark those guidelines and go back to them at your practice just to be able to point to those and walk through it. And then what are the key features to talk about? Well, when you see the brain MRI, make sure the pattern looks like very early Alzheimer's disease, which should basically be a normal scan. We don't expect atrophy in the early stages. But if they've had a lot of infarcts or other pathology, that might actually explain the dementia, and they may not be a great candidate for therapy. We also need to be sure to talk about these baseline features of microhemorrhages and siderosis. So these are features we know of as cerebral amyloid angiopathy. People are at increased risk for developing adverse events during their therapy if they have these on the baseline. So you need to make sure that you collect the right scans at baseline and that you report this out at baseline very carefully. And then finally, for amyloid PET, the key here is for these therapeutic decisions and for monitoring, it's very, very helpful to include that centiloid standardization, even at that baseline scan, because down the road, when they're looking at the response, it's helpful to know where they started. And so with that, this will wrap up our quick update on imaging in dementia. And I just wanted to give a shout out to the Alzheimer's Disease Research Center here at Washington University and all of our staff and volunteers that have been part of this for so many years. We do have time for questions. So the first question I see is, CMS requires a stated intent to use monoclonal antibodies to establish medical necessity for amyloid PET. Any thoughts or potential for change authorizing on Medicare patients? So that's a great question. I don't know the answer to that. I will say that we have not had any problems with reimbursements for these amyloid PET scans, but they are coming through our dementia clinic with people who are being evaluated for potential therapy. And so I guess the issue is that if somebody is refusing therapy but just wants to know their result, it sounds like CMS may not be authorizing that for some people out there. Yeah, I'm not as familiar with that. Okay, next question is, how is the centiloid scale used to determine eligibility for therapy, and are there cutoff values for initiation and discontinuation of treatment? So the centiloid scale is helpful to assess beyond just the visual positive or negative. The therapies themselves do not have a recommendation for cutoffs, but it's being operationalized by different centers based upon the clinical trials and what numbers they used for enrollment and therapy. As I mentioned earlier, at Washington University, we're using the centiloid of 30 as our marker for clearance. I do know that some research studies go as low as 20 or 25 for positivity, but we're using 30 in our clinical population. The next question is, how important is a Z-score value in Alzheimer's disease? The Z-scores are common with a lot of the software for processing the PET scans, and it can be very, very helpful to the neurologist in order to identify how something is, basically where abnormalities are and how they're different from controls. My own experience is that the Z-scores are extremely helpful when you're looking at the FDG PET scans, because those are harder. They don't have a standardization like a centiloid to put with it. And the Z-scores can also be very, very helpful in my own experience with tau PET, because you're trying to look at regional values within the tau PETs. I think for the amyloid PET scans, though, the centiloid is the quantification that was used in the trials, and so is what I would personally recommend. All right. Next question is one we get all of the time. So this is regarding the MRI scans. So as most of you know, we're going to see more microhemorrhages at 3 Tesla than at 1.5 Tesla. We're also going to see more microhemorrhages if we perform our sensitive sequence like susceptibility weighted imaging. Versus the gradient echo or T2 star type approach. The issue is the clinical trials used the T2 star, and so how do you decide which way to approach this? If you look at the ASNR manuscript that we gave you the link for earlier, there's a really nice figure in that paper with a pyramid that basically says walks through these decisions and choices. A lot depends upon your scenario. So you know, if all of your scanners are 3T and have SWI, and you discuss this with the neurologist and they want to know that the risk assessment, then the 3T SWI is definitely the way to go. For my own system, what happened is we're geographically spread out across Missouri and Illinois. And I don't have 3T scanners with SWI across the 300-mile radius that we cover. And so what we decided to do was obtain the 3T, SWI, and GRE at the baseline visit, and then do the monitoring at their community sites using 1.5T usually. And they all had the GRE T2 star. If they also have SWI, we add that on. That way we can assess the greatest risk up front and not be surprised by it. But it does mean that, yeah, we'll probably miss some of the small findings during monitoring. And it's just one of those tough choices. We decided that it was this compromise worked for us because we wanted to be able to treat patients where they lived. All right, next question is regarding tau PET. So are tau PET scans being reimbursed? So this is a question I get asked a lot, and I ask other people a lot as well. So for those of you who aren't familiar with this, reimbursement is determined regionally in the US. And so talking to my colleagues, so right now we're in June of 2025. If you're watching this video in the future, you may have a different answer. Right now in the US, they are being reimbursed on the East Coast, and they are not being reimbursed on the West Coast. And I can't find anyone in the Midwest who's had enough of them go through to know for sure. So that is an interesting way that our healthcare system works. Okay, the next question is, what do we know about the effects of these medications after 18 months? So not a lot. So with these two therapies, although they are approved and covered by Medicare, Medicare also required a registry. So all of the patients going on these therapies have to be enrolled in an approved registry. And there are two big ones right now in the US. One of them is run by Medicare, and the other one is set up by the Alzheimer's Association and works in conjunction with the American College of Radiology, and it's called ALZNet. And in the ALZNet registry also includes the images. And what we're doing now is learning from the experience of these patients as they go forward, because the clinical trials don't go out that long. So we don't know for sure. What we do know is that the risk of the adverse events, the amyloid related imaging abnormalities, so that MRI, vasogenic edema, and hemorrhage, those are most common during the first few months of therapy. So that's why when patients go on therapy, they're going to have 4 or 5 MRI scans in the first 6 months to monitor for asymptomatic ARIA. And then after that, the recommended monitoring drops off. All right, well, I just wanted to say thank you all for your attention. These were great questions. Thank you all for your participation.